Okay, good. So let's talk about head injury now. Okay, 35-year-old brought in by ambulance to emergency, 80 kilometers an hour, motorbike versus car. What's your initial approach? If anyone's done trauma recently, do you want to just have a chat with me about this?
I've done trauma vivas.
Yeah, trauma viva. It's all about theory. Go for it, Matt. Tell me. I'll offer you information as you start. So,
Sure.
this is all you've got. You're with the trauma team. You've come straight away with no initial planning or warning.
Great. And at a moment, trauma center, or is this a peripheral site?
It is a trauma center.
Right. So I'd attend the emergency department, introduce myself to the team, ensure that a trauma call's been activated, and then ensure that they want me to take over the airway role in this, because most likely they're going to have a trauma team leader.
I'm going to stop you there. So that's really great. I speak to a lot of IMGs and they don't have this version of what we do. You know, they're like, this is not necessarily something a lot of the IMGs that I talk to train. So just for everyone out there, what you said there about I would attend, I would, announce myself that I'm the anesthetic person and I'll take care of the airway and or lead depending on the seniority. These are all really useful things to quickly get out of the way, just as a quick spiel at the start. So very good. Let's say you are the senior person at this particular trauma team. Keep going.
So assuming there wasn't any need for urgent, imminent intervention, I'd get a missed and ample handover from the retrieval team that had brought the patient in before undertaking a primary survey, ensuring the patient had a patent airway, cervical spine immobilization, making sure their breathing and ventilation was adequate and safe, and intervening if required, making sure they've got large bore, like 16 gauge cannulas ×2 with bloods taken, and make sure there's cardiovascular stability, assessing their GCS and any sedation that they're currently on, and then exposing the patient for any other injuries, including a log roll. In doing all of this, I'd also include a trauma series that we could do in the bay, including a chest X-ray, pelvis X-ray, and EFAST to look for any obvious reversible injuries.
Sounds good. Tell me about your secondary survey. What does that include?
So secondary survey, once stability is obtained for this patient, and once there's nothing that we need to urgently intervene on, is a more thorough assessment of the underlying mechanism, their past medical history, medications that they might be on, and then a full assessment of all systems, especially looking for limb and long bone injuries on top of the original sort of core systems that we've analysed, and then further to that, investigating with imaging as required, which for someone like this is most likely going to be or almost definitely going to be a CT trauma series pan scan.
Yeah, sounds good. So I like what you did. So we're looking in more detail, a top to tail assessment of the patient, log roll, investigations, and I put my ample history at that point. You often get it at the very start. What does ample stand for?
So allergies, medications, past medical history, when they last ate, for what it's worth, and then I think last eaten it might be, but
E is events as well, which is
events, which is kind of like the missed handover, I suppose.
Good. And again, so this is a very familiar thing that we'll offer to get as much history as quickly as possible. So I've just said here, there's a trauma patient with a head injury, multidisciplinary management, EMST principles, first primary, then secondary survey. You did something good that I just want to draw attention to. When I see a trauma survey, I'm ready to give all the detail I could possibly give from an A to E manner, deteriorating patient style plus C-spine. I first offer primary, then secondary survey, and then if it looks like I need more detail, and that's what the exam is about, great. For the airway, I said, listen for any signs of air obstruction, and I put a C-spine collar. Depending on what I get at each stage, I might just move quickly like Matt did and just go breathing, I'd assess any issues with breathing and optimize with oxygen monitoring, respiratory rate, et cetera, and offer a few things. And then depending on what the examiner gives me, I will go, okay, this is a thorough assessment. Great. I can give you a thorough assessment. I check the rate, I auscultate the lungs, I check for the trachea, I look for the effort of breathing. I mentioned that I check the SATS probe, I apply oxygen and assess their ventilation as well, and intervene as required, wait for more information. So at each level, I'm giving them brevity and then offering more and more depending what the examiner is giving back to me. This might be just, I do a primary, secondary survey and the examiner goes, great, this is what you find, and now we'll move on to the next stage of something. So just wanted to give you that as just a bit of an insight. So you need to know all your A to E, but giving minimal detail at the start and giving more and being ready to give more as required. Okay, so yeah, essentially primary, secondary survey, cerebral protection, ICP, and CPP management, because this patient does have a head injury. Primary survey, which we've just gone through. Good. Secondary survey, which is the ample history, head to toe, and other investigations. Okay, so the case is now, what you find is that you've got a 35-year-old motorbike, sorry for the joke about doing a cyclist, previously well, ASA1, nil allergies, no meds, helmet's broken on impact, and they're in a collar on a spine board. The heart rate is 120, blood pressure is 90 on 60, and SATs are 95% on 4 liters Hudson mask oxygen. Patient is moaning incomprehensibly and combative. And so just to keep going broadly, what types of head injuries are there? There's primary and there's secondary, but there's actually lots of so I'm sorry about the question, it's a bad question. What is the importance of primary versus secondary, Nami?
So primary head injury is actually on impact. So it's like an extradural hematoma. It's something that you can do something about, so evacuate it.
Yep.
Whereas secondary is optimizing all your physiological parameters like oxygenation, carbon dioxide, and blood pressure to prevent that secondary brain injury from getting worse. Is something we can do something about.
Exactly. That's so great that you said that. So the primary impact, it's already happened. Obviously, you need to treat it and you have to evacuate the clot. But essentially, you suffer neuronal death, and it could get worse. And if it, so you've got to make sure that you treat that. But the secondary injury is what's salvageable. So everything we do, it's almost like we've lost the primary already. We just got to get this secondary injury under control, and we do a lot of things to prevent that. So the primary injuries are essentially impact or acceleration, deceleration, focal stuff, which is common to us. So fractures, contusions, lacerations, and hemorrhages, and then diffuse axonal injury. I mean, what do you see here? What's this one?
It's I think it's an extradural hematoma causing line shift.
Exactly, good. Extradural hematoma, you can see there, and you pretty much loss of the sinus here, and you can see a bit of midline shift. So that's pretty obvious. And you see a lot of the loss of the delineation as well. I think you can see a fracture on this side here, just around there, potentially, if that's not a suture line. Oh yeah, in the bone window, skull fracture without dislocation can be found at the site of the hematoma. Good. What do you see on this one, Nami?
I think this is intraparenchymal hemorrhage. It's a lower cut.
Oh, it's not intraparenchymal, but it follows a pattern. The shiny stuff, the white stuff.
Shiny stuff. I don't know, intraventricular hemorrhage, like a subarachnoid, and
yeah, that's a subarachnoid hemorrhage. Excellent. And you can see it kind of follows the cistern patterns, right? So this one, just to be specific, when I got this, on the enhanced CT scan, the basal cisterns are filled corresponding to a subarachnoid hemorrhage. It's the most common cause of subarachnoid hemorrhage. Good. How about this one, Nami?
So it's bilateral subdural hematomas.
Yeah.
And loss of sulcal effacement, so maybe increased pressure as well.
Sounds good. So yep, we've got bilateral subduals. This was actually middle-aged chronic alcoholic male for this. Hopefully what we don't become after this exam. And good. So we've got 2 lesions here. You've got an extradural and then a contracute injury showing some intraparenchymal hemorrhage on that side as well. And then this one, again, intraparenchymal hemorrhage. I just want to show you a few things. Look, I did very little of CT. I did very little of this kind of study for my exam, but I just really wanted to get those initial patterns really recognizable, because there was just, I think those at the very base level, that was pretty examinable. So I'd almost suggest going on Radiopedia or whatever resource you have and just firing up some chest X-rays, some radiology, and just getting used to seeing patterns of what things look like. Obviously they're not going to expect you to be radiology level, but being able to describe things in a systematic fashion, obviously very useful. So what is diffuse axonal injury? I'm just going to go through this. I don't think it's that examinable, really. I haven't been asked too much about this ever. But it's the result of shearing forces, typically from rotational acceleration. It's characterized by multiple focal lesions with a characteristic distribution, typically located at the gray-white matter junction in the corpus callosum, and in more severe cases in the brainstem. So non-contrast CT is insensitive, and MRI is the modality of choice because it's sensitive to blood and edema. We'll show injury even with an entirely normal CT. So maybe just a bit of useful information. Grading the severity of diffuse axonal injury really is just, you know, the amount of loss of consciousness. So say there is loss of consciousness that's transient, then less than 6 hours, 6 to 24, greater than 24, and days to weeks. So what contributes to secondary injury? I think this is pretty common, but essentially the systemic factors, so hypoxemia, hypotension, hypothermia, hypoglycemia, and hypocarbia, especially if it's prolonged. And then intracranial, so mismatch of essentially substrate delivery and demand, unevacuated hematoma, raised ICP, edema, vasospasm, and seizures. So all the things that you could imagine, like you could literally just list off all your ABC type factors and then any kind of intracranial lesion, and that would constitute a pretty good answer to this question. Okay, so what are your management priorities? Let's see, we should go through this. Actually, we've already gone through this a few times. So prevent secondary brain injury, and we're going to maintain our cerebral oxygen supply and demand, which is a lot about maintaining your CPP and avoiding, you know, problems with increased ICP, seizures, a lot of the things that we just mentioned there. If you targeted any question about preventing secondary injury to systemic and intracranial factors and how I would address each of these factors as they arose, I feel like that would be a decent framework for an answer. Okay.
So I just do have a quick question.
Go for it.
If you've got someone that's got, say, a big intra-abdominal bleed and a head injury, I know that you would sort of likely have to treat the abdominal injury first, because if someone's bleeding out, they're not going to have much of a preload in order to, you know, maintain their cerebral perfusion pressure anyway. But you do aim for a slightly higher target blood pressure in that situation, wouldn't you, because of the brain, accepting that there might be more blood loss? Like, what's your sort of strategy for that?
What's your strategy?
Well,
actually, let's start again.
Yeah.
If you have someone with a head injury and no other injuries, what do you aim as your map?
So I want a map of at least 80, assuming my ICP is 20. So
yeah, good.
So, yeah.
I've heard 90 as well, but
80 to 90, yeah.
Somewhere in that range is good.
Yeah.
And now, how about if they've got no head injury but intra-abdominal bleed? What is your?
Well, I'd probably be going for a map of around 60, 55 to 60, with a systolic of 85 to 90, depending on their other comorbidities as well.
Yeah. Yeah, good. Okay, so now we've got a problem where you've got two conflicting priorities. What do? Now your motorcyclist in that previous case, this patient has, I'm glad you brought this up, by the way, because there's actually something I used to ask and I can't remember why I haven't asked it. Maybe it comes up later. That's right, let's do it now. But this patient has both what seems to be like free fluid on a fast scan. They're very concerned due to a lot of swelling and bruising in the abdomen that they've got intra-abdominal bleed, but also have a serious head injury and a GCS that is deteriorating. And both surgeons really require this patient to go to theatre for immediate trauma, trauma surgery on many parts of their body. What do you do about this blood pressure?
So I guess you've got to think about what's going to kill the person quicker, which is probably going to be your intra-abdominal bleeding, accepting that, so I'm assuming that you would have to accept a compromise such that you might aim lower than normal. So you might aim for a MAP of 70, depending on the degree of blood loss, and titrate your accepting that, if you were to aim a MAP of 80 to 90, like you would normally do with a neurosurge case, that by doing so, you may not ever achieve that anyway because the patient's bleeding out. So you'd have to sort of weigh it up, would be my response.
Yeah, okay. And so the only thing I'd say is you took a lot of words to get to an answer, which is it's not a bad thing. But, but you know, like, I'll ask you a few questions. Do you think anyone knows what to do?
No, I think it's a compromise.
Okay, great. So just say, look, this is hard. I've got two conflicting priorities. It'll be a compromise. What I'll do, I think, is to try and maintain a map of 80 to 90, understanding that this is not hypotensive resuscitation, and I will expect to give more blood for this patient. Maybe I'm not in a quaternary hospital with 1,000 units of blood in the back, and I'm in the country somewhere just trying to manage this as best as I can. Look, this has two conflicting priorities. I really would like to, I may have very limited reserves of blood, so I will prioritize hypotensive resuscitation, understanding that I may have problems with brain perfusion and lack of CPP because I'm addressing this priority. I think depending on the circumstance, you could do either, but the critical thing for this exam will be saying, this is a problem. I got two things I want to do. I can't do both of them, and I'm going to make a decision. Full stop.
Okay. Yep. Okay. Thank you.
That's good question. And I think that's one of the big things that we have to just get used to, really. Okay. So have a think about neck injury, so C-spine clearance. Let's say you have a 20-year-old male who's post a fall from a ladder with a head strike. My questions to you are, how would you clear the spine? What rules do you know? And which is more accurate? So I know that there's two rules to clear the spine, Nexus and Canadian C-spine rules. So that's good that you knew those. Which is more accurate? So it's funny, the Canadian C-spine rules are more accurate, but I found that local hospital guidelines often may do a combination of these. Realistically, they're all very conservative. So as soon as there's any high risk factor, you just go straight to radiography anyway. So there's definitely a tendency, especially in trauma hospitals, most of the time, most of the normal trauma that you'd get, you'd end up going for a scan anyway. So that's the Canadian C-spine rule. So any high risk factor, age 65, dangerous mechanism, or paresthesia in extremities. If it's any low risk factor that allows safe range of motion, able to rotate the neck actively left or right, yes, and then there's no radiography. Nexus criteria is cervical spine radiography is indicated for patients with trauma unless they meet all of the following. So no posterior midline cervical spine tenderness, no evidence of intoxication, a normal level of alertness, no focal neuro, and no painful distracting injuries. And then when they put these head to head, so this is New England Journal of Medicine article from back in the day, the Canadian C-spine rules were more sensitive than the Nexus score, 99.4 versus 90.7%. So conclusion, for alert patients with trauma who in a stable condition, the Canadian C-spine rules is superior to NLC with respect to sensitivity and specificity for cervical spine injury, and its use would result in reduced rates of radiography. Okay, so back to the case. This is your case. You arrive in ED and review the updated info as per the paramedics. What do you do before the patient arrives? So yeah, I think Matt also did this pretty well, where you ensure a trauma call, introduce yourself, various specialists are available, check your own equipment, and in this particular case, you might want to check with blood bank. And just remember, in the exam, in real life, a lot of this stuff gets done for you. There's systems in place. But when you're writing out a short answer question, it's just so useful to have formats and frameworks so you get as much content out so the examiner can offer you marks. So we've done this a bit. So we've described our management. So I might leave it there. Actually, let's do another one. Who's next? Hey, Queenie, can I ask you about this patient? So let's say you have that 35-year-old, let's backtrack a bit, and they come straight into the trauma center, and you're there as the leader of the team in this future situation, and you're trying to do your assessment. Tell me about your assessment, Queenie.
So airway-wise, I would assess for patency, if there are any foreign objects within the airway that need to be suctioned or removed.
And as you approach the patient, he's flailing about. You can't seem to really get near him. He's shouting incomprehensibly at you.
So this is a difficult situation because he will need a adequate assessment, and potentially he may need pharmacological assistance in order for that to occur. As a team leader, I would liaise with my person who is in charge of airway and breathing, which hopefully would be an airway trained person, such that we could safely administer a sedative agent while simultaneously securing the airway with C-spine precautions.
Okay, good. So let's say as you're trying to administer medication, the patient doesn't have a drip in, they're flailing around, they've definitely got trauma all down the left side of the body, and the helmet was impacted, so they've definitely got a head injury as well. And you can't really get too close to the patient because they're flailing. What do you do?
I would still describe my concerns to the team and liaise with my airway breathing person whether or not we should give an intramuscular agent prior to then securing intravenous access, and then expediently securing the airway with C-spine precautions.
Okay, and because the patient's flailing around, how are you going to do that? This is a tough situation, by the way, so you're doing well. Like already you're going down the track I want you to go down, so you're doing well, so keep going.
Presumably the rest of the trauma team are there, and that we have security available who would be able to assist us in safely and carefully holding down this patient so that we could administer what medication we need.
That's right. So I'll get security to apply, say, a 5-point fixation of the patient for the patient's safety and for staff safety, and then administer an intramuscular dose of, say, ketamine. How much ketamine would you give intramuscularly?
I know the induction dose is like 2 to 4 milligrams.
Yeah, sounds good.
So less than that or more than that.
Yeah, that's right. And depending on what your experience is, you can probably choose any number, because you could do a delayed sequence intramuscular induction type thing, maybe give 1 mic per kilo or 2 milligrams per kilogram. I suspect that just giving the whole 4 milligrams per kilogram is probably what you need to get control of the situation urgently. Now, this is an incredibly tough situation, by the way. So what are you expecting to, let's say you do have to give 4 milligrams per kilogram of intramuscular ketamine. What are you expecting can go wrong, and now I want you to preempt that and say it.
I guess the problem would be potentially a reduction in GCS and airway protection.
Yep, great. You got your airway to manage that and get it ready?
Yeah.
Anything else? Let's say they've got trauma all over the left side of the body, obvious leg fractures, abdominal injuries.
I guess if you're taking away their sympathetic nervous system drive potentially, if it's already maximal, and it could worsen their hemodynamics.
Exactly, good. So as part of this strategy, I am now communicating, like I think this is important in real life, but also in the Viva, that I'm saying, look, this is a bad situation. I'm getting the patient safe. I'm giving something to get them asleep so I can now keep them safe and assess them. But I know that 4 milligrams per kilogram of intramuscular ketamine in a severely, potentially very hypervolemic patient can cause cardiovascular collapse. I'll have adrenaline, ephedrine, intramuscular ready, drips ready, ultrasound access ready, whatever I need to get all of that ready, because this could go very bad, but I've got no other choice in this matter. The reason I'm giving you this situation is I've just told you that I want you to know your A, B, C, D, E assessment back to front, so you can just offer a whole storyline, make assumptions, keep talking. But in this exam, from my experience as an exam observer, they will give you a situation where it sounds like you've got to go through an assessment like EMST, and they'll deliberately make it impossible for you to go through EMST. So you very quickly said, after I was like, oh, airway, he's flailing about, you can't get next to him. You very quickly went to the decision to sedate, which is exactly the right thing to do. So in the exam itself that I was observing, every single candidate, because they're in exam mode, suddenly they were thinking, oh, I've got to say EMST. So they took so long to get to the point of sedating the patient because they felt like it's not the right exam answer. So I guess I want to give you the confidence that they will make it's almost like if they give you a flow chart to follow, it's too easy. They want to make it a bit tricky. And I think it's probably fun for the examiners to make these crazy scenarios as well. But anyway, so you're right to deviate from the plan, from the protocol, and then manage the complications as they were going to happen. So yeah, that's good. Good. So GCS, Glasgow Coma Scale, or GCS, is a neurological scale that aims to give a reliable and objective way of recording the conscious state of a person for initial as well as subsequent assessment. Eye-opening, motor, and verbal response are assessed, resulting in a score between 3 to 15. Remember, one of my registrars saying it's the best kind of score because you get 3 just for turning up. And I usually get a few laughs for that one, but it's Zoom, so I don't. Damn. Have a go at writing this down, but I'll just give it to you just in the interest of time. In the MCQ for the Part 2 exam, they always had the GCS as a question, and it always came out at 11 in all the years of practice exams. And I remember I would just do it just for the sake of learning it. And on the exam day, it was slightly different. Like there was a slightly different verbal motor response, and the score was 10 or 12, not 11. And I was just thinking how glad I was that I memorize this for this exam. So just to let you know that that's how sneaky the examiners can be. But that's probably fair as well, because we're not meant to be doing past papers. Anyway, so that's your Glasgow Coma score, worth knowing. What are the indications for intubation? Again, imagine getting this on the exam. I want you guys to have a pretty decent, thorough answer for this, because it's kind of what you do day in, day out. And I think we all take it for granted. So maybe take 30 seconds to think about what are the indications for intubation, broadly speaking, maybe absolute and relative together.
So indications for intubation would be if there is severe head injury with a GCS score of less than 8, if airway patency or ventilation is compromised, if the patient has blood or any other foreign substances that could obstruct his airway.
That's good. Any other situational things?
Yeah, and I guess if you see that there's hypoxia or hypercarbia, to try and gain control of that and optimize the cerebral perfusion pressure.
No, that's good. You got the main ones, okay? So the clear ones are any kind of respiratory arrest, poor oxygenation, and ventilation. You got that. Any kind of difficulty in airway protection, absolutely. Intubation, you've got to protect the airway, especially if they're unfasted. Then foreign bodies bleeding into the mouth, any obstructive things, absolutely. You may need to intubate those. And then the other things, you often see that these patients get intubated for seizures and for treatment of seizures, especially if you're running big doses of whatever it is, propofol, thiopentone, midazolam, enable CT scanning in an unstable patient, and stabilization for transfer. So just a few of the other reasons that you might think about intubating. I thought that was an interesting kind of question. I can't remember if this was exactly an SAQ, but again, these SAQs are thinking really broadly about all the reasons you might do something. Good. How would you program the ventilator? So yeah, I was just I was just thinking about a head injury patient. Obviously, oxygenation is absolutely mandatory. Maintain SATs above 97%. Adequate volumes to get an end-tidal CO2 normal or slightly low normal with a PaO2, I guess 35 to 40 or 30 to 35, and then maybe no PEEP unless there's issues with oxygenation, because you're trying to just really maintain that venous return as well. Circulation, large IV access, arterial I aim for a cerebral perfusion pressure of 70. So for that reason, I aim at a MAP of 90. Assess source of bleed and expect blood loss. And then we talked about this. So assume patient has free fluid in the abdomen, looks like class 3 hemorrhage, but also have a GCS 8 and likely head injury. So now we've got the two conflicting problems that we talked about. What blood pressure do you aim at? It's always challenging. And what do you do about hypertensive resuscitation? So you've got two conflicting priorities, and you'd really have to talk about that. But yeah, at the end of the day, you just have to make a decision, and it could depend on the situation. How do you assess the severity of head injury? GCS is probably the most straightforward way of doing it. And this little score here, mild, moderate is 9 to 12, less than 9 is severe, or 3 to 8 is severe. What are the signs of imminent coning? Yeah, so unconscious patient, hypertensive, bradycardic with dilated pupils. Again, if you get this pattern, obviously this is a real problem that needs very drastic and urgent attention. Immediate management, we've kind of gone through this before, but positioning, pharmacological, physiological, and potentially surgical treatment of this. And good, we've already gone through this again, but worth reiterating. Head up, loosen ties, avoid people, manage the intrathoracic pressure, and a lot of agents to help directly and indirectly, mannitol, furosemide, muscle relaxants, avoiding nitrous, decreasing your volatile TIVA, thio and propofol may be required as a bolus, and then maintain all your physiological variables to as normal as possible, and potentially hyperventilating to get your CO2 down, and then surgical evacuation of CSF or clot and a craniectomy, depending on what the neurosurgeons require. With mannitol, hey, so who knows what percent mannitol comes in and what volume?
20%.
Yeah,
There's a 500 ml bag is what I've seen.
And how many grams is that?
Well, that's 200 milligrams per mil.
Yeah, good. And that comes out at actually 100 grams, which is interesting. So you're absolutely right. 100 grams of this, 100 grams. So when the surgeon asks you to give a dose, how do you weight this out? So obviously the fact that it's 20% is 200 milligrams per mil allows you to calculate any amount. But I remember just the quick thing we learned was it's usually the grams that they ask for. Grams times 5 equals the amount of mils. And so that was just a little cheat that we used to have for the volume that we have to give straight away.
Hey, Lahiro.
Yeah, go for it.
Well, I don't know if this is easier, but I just remember that if you give 0.5 grams per kilo, that's 2.5 mils per kilo.
Nice.
And then I just calculate it up.
You do your way, I do my way. Carolyn, don't tell me what to do.
Sure. Sorry, boss.
I'm kidding. It's all good. 25-year-old man with history of blunt trauma to the right side of his head has a fixed dilated pupil. He's been intubated and ventilated in the emergency department after initial GCS of 15. An admission has now fallen to 3. It's pretty drastic. Evaluate the pharmacological and non-pharmacological methods to manipulate this patient's intracranial pressure. Look, we've already gone through this mainly. So I thought I'd just kind of mention this briefly. Yeah, just have a summary statement of the issues, a definition of ICP and the Monro-Kelly doctrine. Karen, what's the Monro-Kelly doctrine?
So the Monro-Kelly doctrine states that the cranial vault is a fixed space that contains CSF, blood, and brain parenchyma, and that in order to maintain a normal intracranial pressure, that the volumes of these components have to change in order to maintain homeostasis, and that at a certain point there will be lack of compensation, and so you'll get increased in ICP.
Fantastic. And you can always do that graph, volume versus ICP, which goes up very sharply as the volume increases. And then, again, an easy way of classifying this: blood factors that increase in volume, venous arterial, CSF, brain, interstitial fluid, and bone. And these are the factors that I can address. Or we can do the phys-pharm, physiological, pharmacological, and positioning issues. Prognostic factors include clinical GCS, pupillary reaction, major extracranial injury, and then CT, particular hemorrhages, loss of basal systems and third ventricle, subarachnoid bleeding, midline shift, and unevacuated hematoma. The DECO trial, so this was a trial that was conducted quite a few years ago, Multicenter RCT, comparing decompressive craniectomy to best medical management, and essentially, improved ICP but poorer long-term outcomes, and no difference in death between the groups. Again, like every study, there's always lots of criticism. So the threshold for defining increased ICP and the time allowed before declaring ICP medically refractory are not what many practicing physicians would consider increased or refractory. Also, the eligibility was not great. So only 155 patients were enrolled, showing that the study cannot really be generalized to all patients with severe non-penetrating brain injury. And despite being randomized, more patients in the craniectomy arm had unreactive pupils after randomization but before surgery than patients in the medical therapy arm, which is a potential confounding factor. So yeah, obviously a lot of problems with that. It was just one of the recent trials that they were definitely doing locally, so probably worthwhile knowing briefly. So let's talk about some controversy. So just to go through everyone here, hey Andrew, what's the benefit of TIVA propofol versus volatile?
So the issue with volatile anesthetic is the luxury perfusion and theoretical increase in intracranial pressure for max above 1. And so TIVA is thought to have less of an effect like this and would benefit by not increasing the intracranial pressure and having an influence on the cerebral perfusion pressure.
Yes, great. So similar hemodynamic stability at emergence, extubation, and early cognitive function, but profile probably decreased ICP bet and has better CPP in the elective craniotomy population. Ben, how about remifentanil? Any evidence for that?
So I know it's a very useful drug in neurosurgery because it's titratable and allows for rapid emergence. In cases where you're doing evoked potentials is very useful because it doesn't suppress your evoked potentials as much as neuromuscular blockade does.
That's a good answer.
It can stop the patient breathing.
It is titratable, yet quicker eye opening, potent, effective muscle relaxation as well. So that's very useful. Unfortunately, may have a higher opioid requirement afterwards, but often very, very useful in this situation. Next person along, BJ, would you use NSAIDs for these cases, neurosurge cases?
Particularly, it has a detrimental effect as far as the antiplatelet is concerned. And if the patient is having chronic NSID, could be bleeding as an issue. That's the only one. And in the setting of decreased hypertensive state, even some kidney injuries in the presence of NSID is also a concern.
Excellent. Yeah, I would agree with that. And they've had no clinical benefit in these cases of adding nonsteroids or paracoxib to local anesthetic paracetamol and or PCA morphine. So potentially those harms that you've talked about.
Yeah.
David Koo, nitrous versus air, what do you reckon? Oh, he may have gone. So Diana, nitrous versus air, what do you reckon?
I probably would avoid using nitrous.
Why?
Potentially some vasodilation of cerebral blood vessels.
You're right, though. Yeah, you're right. Look,
expansion of air in spaces if you do get an air embolus or something like that. But.
Absolutely. So there's not great evidence on this, but at best, there's no harm or neuroprotection. So there's, at best, it doesn't do any harm, but at worst, it could be neurotoxic. It could raise your ICPs, give a poor surgical field, and if there's any embolism issues, it would be very bad for that as well. We've already talked about subarac, targeting euvolemia. There's harm with aggressive fluid resuscitation, as we mentioned. Routine phaneitoing is not recommended. Modest BP elevations we've talked about. Routine pulmonary artery catheter is not recommended. And a CVC solely for CVP and fluid management is also not recommended. And often we just go for loose control of BSLs rather than tight control. Usually this is because of the risk of hypoglycemia being devastating for a patient. Good, just some controversies. So again, I imagine if you're in the Viva or you're just writing out some answers, offering this kind of information with quick notes about some of the issues around them is probably a way of getting quick marks and sounding sharp. Okay, so we've gone through now trauma and head injury, primary then secondary survey, and a few nuances around that, fouling protocols, breaking protocols, primary injuries being focal or diffuse. Secondary injuries are the preventable things. A lot of what we do is to prevent that secondary injury. We've gone briefly through the C-spine management to about the level we probably need as anaesthetist, and then a trauma management sequence, and talking about the conflicting priorities as well.